Welcome to Orthopedic Indications. My name is Nick Strasser, and I am putting this together after our AOFAS meeting, talking about Achilles tendon repair. And so I thought I would just put this together on a recorded version and kind of see some of the Achilles tendon repairs and really talking about the different treatment options that we have. These are my disclosures as it relates to this talk. I do some consulting for Arthrex on this, so that's probably relevant. When it comes to minimally invasive surgery, Achilles is probably one of the first ones to really accept using Achilles tendon to accept minimally invasive surgery. Back in the 1970s, Ma and Griffith described using stab incisions to repair this on the medial and lateral border, passing sutures through the tendon through these kind of small incisions. Actually have pretty good results. No reruptures, two skin complications, small numbers. It was repeated and by others in 1991 described 13% of 38 patients had a sural nerve entrapment. So that became kind of the issue with the repair. We remain interested though, because Achilles wounds have been always challenging. And so they've evolved over time to include something called the Tinolac, the Aculon, Dresden, PARS, and then now eventually the PARS mid-substance. This is a little bit of the way I see the progression of things through time. What are these different types? Well, the Tinolac is mostly available in Europe, out of France, I believe. It's a percutaneous repair device that almost feels a little bit like zip ties, where you pass these barbed sutures through the tendon to pull the two tendon ends together. The cool thing is you actually avoid exposing the tendon site itself, so it kind of bypasses it. But as you might imagine, there could be some complications with it, and you have to take out the sutures eventually. So it's not the perfect system, but it's certainly out there. It's been around for quite some time. Aculon came around after Kakeuchi described using a suture guide that he made with looped Kirschner wires, and then he inserted it under the peritoneum from the rupture site, and being able to do that with kind of a minimal incision. And then he turned this into this jig called the Aculon, which facilitated repair of the Achilles in these particular situations. And certainly another reasonable option has been around for a while. I believe it's no longer available in the United States, but certainly something else to consider. And Dresden is another system that's out there. This is a technique description than a particular system, but you have these Dresden tools that you can actually slide extra or outside the peritoneum and then pass the sutures through accordingly. Traditionally, this talked about doing these sutures distally, just above the calcaneus, and then using a Greifhoff stitch in the proximal aspect of the tendon. Again, kind of avoiding disrupting the peritoneum, which has some attraction from biomechanics or blood flow and vascular preservation perspective. Then we know the Arthrex has PARS and PARS mid-substance. PARS is a suture to suture, so suture passed both proximally and distally. PARS mid-substance, which is proximal fixation and then taken down and anchored down into the calcaneus. And certainly both of these have been around for some time and now show pretty good results. I'll talk about those later. And then there's some hybrid techniques, and this is not in isolation, but you kind of get the idea that in this case, they're using the PARS jig to pass the sutures proximally, and then all of that gets taken distally down into the calcaneus and fixed with anchor fixation, but bypassing opening where the tendon is torn and actually staying outside the peritoneum in this particular case. The questions always comes up is biomechanical strength. Achilles tendon repairs compared to, say, like open, which we considered the most commonly accepted repair technique. And what's interesting is if you look across these percutaneous types, this is mostly with Aculon, PARS, or mid-substance, you see there's a little bit of there's increased displacement with the percutaneous repairs, especially over those first few cycles. It gets less as you get up to 10 to 100 or 100 to 250 cycles. One of the things we really like to do is cycle the sutures and make sure that they have good purchase and remove any creep from these cases. And then if you look to load to failure, very open to PARS, they're pretty similar in terms of their biomechanical strength. Now, admittedly, this has all the challenges that are associated with some of these cadaveric biomechanical studies, but you can certainly see that there is some advantage to some of these cases, or quite a bit of similarity, I might say, in these different cases to using a percutaneous repair technique. And if you add the PARS mid-substance, which then eliminates some failure points, such as taking the suture distally, and now instead taking down the calcaneus, that removes some of the creep, and it improves the strength quite a bit. As you can see here, almost 400 newtons compared to the open repair, which was a lot less. That 275. So what about patient outcomes? If you can take it down to the heel, does that help improve your strength? But downside being that now you're drilling into somebody's heel where they can have heel pain where they no longer had heel pain before. This is a relatively recent study. This is Anish Kadakia's paper looking at 2 MIS techniques for Achilles tendon repair using the PARS, comparing it to mid-substance. This is patient surveys in all the kind of similar patient population with acute Achilles tendon ruptures. And what they found was really no difference in terms of rerupture rate, complications of return to activity. Actually, the mid-substance had a slightly better AOFAS and FAM score, though not statistically different. There was a higher incidence of heel pain in the mid-substance at 7.3, but actually came down substantially when they changed the trajectory a little bit. And I'll talk about that in a little bit, from more proximal down to distal, from proximal to distal as opposed to posterior to anterior. So both of them can provide good outcomes. It really comes down to surgeon preference, tendon quality, and repair location in terms of deciding what type of anchoring system you're going to use. Now there's some more newer techniques that are out there, including a company called Astron, which uses ultrasound through these pretty small incisions, passing these telescoping needles through the tendon, and then passing the sutures through and repairing them in such a fashion. Certainly another thing to kind of think about from a Achilles repair system. So is it worth it? Is it worth all the headache of learning how to do something minimally invasive? If you're very comfortable doing it open, you can kind of see everything, you know exactly where the sutures are going to get passed. There's been a number of studies looking at this. This is a meta-analysis and systematic review of 8 studies. What they found is that the complications in them were fewer, especially when it relates to wound infections. Rerupture rate was the same between the two, and functional outcomes were essentially the same. So I think there is some conclusion to be, there's some weight in saying that it does offer similar functional outcomes with fewer complications. Now, one of the challenges with any of these is there's fairly high heterogeneity, including some different techniques used for all the repairs. And so, yeah, I kind of highlighted what some of those looked like earlier. And so there's no real standardization to really know if it's head to head with one particular technique, is it actually better? But if you take all comers, which may be more representative of kind of the patient population, it seems to be worth it. What's my preferred technique? I do a lot of PARS repairs, and so I use the PARS jig, and I do this through a vertical incision. I just find it heals better. I have to credit James McWilliams with this modification that he posted on, actually, and communicated with him offline on this a bit. But this is kind of the repair that he's advocated, and I really like it quite a bit. So slide it in, you put your 3 sutures, pass through, except for that proximal one, I use a looped passing stitch in the most proximal incision. And then I use 2 of those. So 1 loop on one side, 1 loop on the other side. You'll see why here in a second. I go ahead and pull those through. I lock that central stitch like you would expect as kind of the standard technique. And then I do the same thing distal, but instead of doing 3 distal, I'll do just 1 that gets locked. So I do the passing technique, shuttling technique to lock the stitch. Now I got a locking stitch distally, and the loop stitches serves as a shuttling stitch for that lock stitch that's distal, because then I take those limbs, pass them through the loop, and that all gets passed up. And so that when I pull those down, it actually cinches the 2 ends of the tendon together. So now I have that tendon-to-tendon apposition after the repair, and then I can take everything down distal, down underneath the skin like you would with the normal mid-substance repair, anchor it down at the calcaneus. One of the criticisms of doing a mid-substance repair is the risk of heel pain. And I think there are some really nuances to be able to minimize the heel pain. And I think it's also worth being said that even patients with a PARS to PARS or suture to suture repair are oftentimes going to have some heel pain anyway. So that's not unheard of, even in the setting of a normal quote unquote repair. So what I like to do is I go just proximal to the insertional ridge. I actually get on either side of the tendon, so I keep them a little, that incision goes a little bit outside so that I can get on the outside part of the tendon and work my way underneath the tendon. And then I will kind of find a little bit of a pocket, if you will, before the insertional ridge. You can kind of see it on the MRI here. There's a little bit of a space. And I'll make that incision, get a little mosquito underneath there, and then find that with my guide, make sure I get my guide all the way down to bone, and I angle it slightly distal or down towards the heel, bottom of the heel. Now, when the foot's plantar flexed, you're going to feel like you're shooting straight downhill. When in actuality, you're still only going to be like 45 degrees or so, but that's fine. It's enough to kind of get the trajectory correct. So it would look something like this on the x-ray when you go to put these wires in. And then I'll bring them converging. I think getting axial is probably pretty helpful just to make sure that you're staying inside the bone and that that trajectory is as you would expect it to be. So I aim proximal to distal, I converge slightly, I work underneath the tendon, make sure you got a drill guide in there to make sure you drill down to complete depth and tap down to complete depth. And then I like cutting the sutures with an arthroscopic suture cutter because it can really help facilitate or minimize any sort of knot that's left after cutting the sutures. I don't worry about cutting the suture as it's coming down when I'm just sticking a knife kind of blindly in there. And that tissue's it's a little bit deeper than you think for the repair. These are pretty recent studies here looking at some of these. I think it's worth mentioning it, and is recent actually since this fall. This is a paper that was presented looking at a Dresden percutaneous repair with PARS, knotless, in 102 patients. So this would be suture to suture versus doing something kind of anchoring into the heel. Functional outcomes were equivalent. Complication rates were much higher in the PARS reported, so 30% versus 11%. And that was mostly heel pain that was driving that. But at least one of my critics, or my side eyes, I guess, is looking at the technique, where it's coming in straight medial in this particular case. And I think, to me, that's a big cause of pain. The sutures tend to like rub on that ridge. And so if you're taking it down to the heel, I do think it's actually important to take it to aim proximal to distal as opposed to directly anterior to posterior, or even in this case, going medial to lateral. I think that can be a pain generator in this particular case. And so I think I take some issue with it that I think the heel pain is probably largely technique driven. So in contrast, this to Kadakia's JAOS in 2025, where he modified the trajectory, and now it cuts down nearly in half, from 14.8% in that paper down to 6.5%. Again, aiming proximal to distal. And I think it's important to note, as I said before, that even in tendon-to-tendon repairs like a Dresden PARS or as anchor-based constructs, there are some incidents that have heel pain anyway. So I think by really paying attention to the technique and making some small adjustments to the way that you do this, I think you can experience better outcomes and less heel pain. And I think Anish does a nice job of showing that. What about complication? We all hate complications, and we know that the downside of open repair has been complications. And we're always focused on trying to identify the incidence and timing. This paper looked at overall all Achilles and found a complication rate of 13.5%. Definitely was more likely to have a sural nerve injury or neuritis with the percutaneous repair, and that's been one of the cons of this particular technique. One of the things to really minimize it is to stay inside the peritoneum, and wound complications were less in the percutaneous technique as well. So there's certainly some advantages and disadvantages. The thing that's interesting is that the surgical delay effect, meaning that if it went up in the invasive group, does longer than the surgical delay for like a couple weeks, the sural nerve injury was higher, which kind of makes sense because you get adhered tissue down to that area. It's a little bit hard to free it up and mobilize it. Maybe it's harder to get between the peritoneum and the tear. And so maybe you don't get inside the peritoneum as reliably. And the same way, though, the open group had an increased wound healing complication rate as well. And then worth noting that VE is the highest across all the groups. It's definitely something to consider. I think staying inside the peritoneum and being really cognizant of the sural nerve is probably really the key to minimizing wound-related complications. I take a lot of time to really test each limb of suture after I pass it through the tendon, so that I really know if the repair is good, that each limb is not giving way. And this would be a case where somebody that was a little more proximal, I could not get good purchase. So in that case, and because I do a vertical incision, I can extend it and do the primary repair in an open technique without any downsides. One of the downsides of the horizontal, and I know a lot of people that use it and swear by it, but one of the downsides is that if you have to extend it for whatever reason, heaven forbid it should fail or other issues arise, you do have to make kind of a Z or an L type incision. It does make it a little bit more complex. I try to keep that proximal limb on the medial side, the distal limb lateral. I feel like that helps me identify and reflect the sural nerve. As you can see here, there's probably a sural nerve injury with one passage as one of those sutures in this revision the case, but it does help facilitate being able to find it, identify it, and explore it if needed. So in summary, the keys to success in the minimally invasive Achilles tendon repair group, I think it's important to that it is a safe alternative to open repair. Definitely a benefit to considering it. It does have a reduced risk of wound healing. Biomechanical strength, I think, is comparable, and there are some technical considerations. For example, making sure you get a secure purchase in the tendon, stay inside the peritoneum to protect the sural nerve. I think when it comes to fixing it, either one is an option. They both have shown to be good options. There are some techniques, tips that I think are important for anchor fixation, such as working under the tendon and drilling proximal to distals, converging slightly, and then staying proximal to the insertional ridge, making sure that everything is fully buried. And I think if you pay attention to those principles, you can anchor down without any trouble. Thanks.